Peter Breadon is Health Program Director at the Grattan Institute, an independent research organisation providing high-quality policy recommendations to help shape Australia's future.
So, we've long argued that you really need completely new funding models to deal with the new disease burden of Australia, which is rising rates of complex chronic disease. So specifically, what we'd like to see is that we move primary care funding from this fee-for-service model to a blended model, where you get most of the funding comes linked to the patient, not to the service, and that patient budget reflects that patient's needs, more for sicker, older, more complex patients. And then where you've got really thin markets with just not enough care to go around, we think you need salaried models there. But for both of these, you'll really get the best results if you get governments working together to unlock those funding models, but support the change that needs to come with it in terms of how you manage those budgets and in terms of how you set up that new multidisciplinary care now that the funding model allows it to happen. I sometimes say Australia has a last mover advantage in healthcare funding reform because so many other countries have gone first and shown the way. And some of those countries like New Zealand and Ontario in Canada, they started out with a model that wasn't great because they just did for age and sex, getting more for looking after women a little bit, more for looking after older patients. And now they've changed that, and New Zealand's changing it right now. So they're bringing in a model where you get more for treating patients who are multi-morbid. They have 3 levels of one chronic disease, 2 or 3. That's all derived from routine data on dispensing. They have 5 levels of disadvantage, so more disadvantage, more money, because we know those people have more health challenges, more for Maori and Pacifica people, and more for people in rural areas. This just really does make sense. When you think about it, the crudeness of our funding model, right? That it's got, not only is it this fee-for-service that really rewards super short consultations, it's got almost no adjustment in the core funding model to take account of need. So no wonder we see our care skewing to wealthier and healthier communities instead of the reverse. Now we want to see it happen. And I think this collaborative partnership here in WA is probably the best place to demonstrate it and make sure it's a success. We have definitely publicly made the case that this reform agreement should, for example, set a minimum threshold of how much care a community needs. And for areas of Australia that are persistently below that threshold, that should unlock the standard governance and funding arrangements to do co-commissioning in those thin markets to give communities the care they need. So that we've said that should be in the National Health Reform Agreement. We've talked about a lot of other reforms that should be in there, and certainly this is the opportunity to do it. It comes around once every 5 years, longer if they roll it over for a couple of years like they have, and that's my hope. I think it's too much money. It's the biggest financial deal between the Commonwealth and state governments in health. If we don't seize that opportunity to break up these silos and make funding follow need, it is a massive missed opportunity. It's no secret that change support from commissioners is critical to success in terms of adopting these new multidisciplinary models of care that Minister Butler has spoken about being so important, in terms of getting those new funding models to work in practice and manage them effectively. So, every review into the big 4 national trials of funding model and care reforms, they all say change support is crucial. So that is the core role of PHNs, isn't it? To really, identify the problems, work out the right solutions, but then really partner with the sector to make it happen. So I don't think there's a world of primary care reform without PHNs taking on that mantle. Look, that's just a long way of saying that I think this is a critical role. And I think a lot of people agree. And as you get into it through this partnership and deliver the changes on the ground, I think that'll only build confidence in that role, and hopefully it becomes a virtuous circle that means this PHN support gets better and bigger as time goes on.
Thanks, Peter. And it does make me wonder as you're speaking. So as PHNs, we talk about the 3 C's: for primary health networks, commissioning, collaboration and capacity building. And I wonder if change, and change leadership is another C for us to really be taking on.
I love alliteration, and it seems to make a lot of sense to me. It's certainly what I've heard from everyone, from clinicians and patients through to policymakers. I think that's been where we've fallen down so often in the past. So getting that right does seem like a key ingredient.